So when we think about hemophilia treatment goals, approach, and strategies, there's a few things that come into consideration. So for hemophilia treatment goals, we think about rapid and effective replacement of missing coagulation factor in order to increase factor levels, decrease frequency and severity of bleeding, and prevent the complications of bleeding. And the best approach for this treatment is through comprehensive hemophilia treatment centers, which are staffed by a multidisciplinary team of experts who care for patients with bleeding disorders. And in general, the two overarching treatment strategies are episodic or on-demand factor replacement or prophylaxis. So when we think about hemophilia management challenges, largely we think about prophylaxis and formation of inhibitors. In prophylaxis, we think about identifying the optimal trough level, so what level of factor should we treat patients at for their desired activities, the cost benefit of targeting those higher trough levels for improving the patient's overall quality of life and prevention of bleeds, the use of prophylaxis in adults beyond the pediatric period, and also perisurgical considerations, so how high should a factor level be for certain procedures and how long should patients be treated, and also the impact of prophylaxis in adults on cardiovascular risk. Also, we think about the formation of inhibitors in hemophilia, which is one of the most difficult side effects to deal with. We think about the genetic predisposition in families and depending on what mutation there is in the factor molecule. And also, patients are at higher risk to develop inhibitors during factor exposure at times of heightened immune response, such as times of major surgery, getting immunizations, or with severe infections. And also with higher and continuous factor infusions in mild or moderate cases of hemophilia. And ultimately, the goal with patients with inhibitors is to eradicate their inhibitor in severe cases. So when we think about treating inhibitors in hemophilia, we know that there's a genetic predisposition. So inhibitors can run in families and are dependent largely on the mutation in the factor gene in those families. And also that inhibitors can form during factor exposure when the immune system has a heightened response, such as times of severe infections in the hospital, during major surgery or immunizations or other immune system triggers. And also with more frequent, continuous high-dose factor infusions in patients with mild and moderate hemophilia. And ultimately, the goal of treatment in patients with inhibitors is to eradicate the inhibitor in severe cases. So when we talk about prophylaxis protocols, there are a few definitions that we need to discuss. Primary prophylaxis is defined as regular continuous treatment initiated in the absence of documented joint disease, determined by physical examination and/or imaging studies, and started before the second clinically evident large joint bleed and age 3 years. Secondary prophylaxis is regular continuous treatment started after greater than or equal to 2 bleeds into large joints and before the onset of joint disease documented by physical examination and imaging studies. Tertiary prophylaxis is regular continuous treatment started after the onset of joint disease documented by physical examination and plain radiographs of the affected joints. And then we think about intermittent or periodic prophylaxis, which is treatment given to prevent bleeding for periods not exceeding 45 weeks in a year. We think of periodic prophylaxis such as when patients have things like basketball season or different sporting events or other activities where they're going to have increased risk of bleeding. So in looking at some of the landmark studies in hemophilia related to prophylaxis, one such study was performed by Manco Johnson and colleagues looking at childhood prophylaxis in severe hemophilia A. This study's main takeaway points was that prophylaxis compared to episodic therapy was better able to prevent joint hemorrhages and other hemorrhages as patients experienced fewer average number of hemorrhages per month when they were on prophylaxis. Additionally, those patients who were on prophylaxis, as expected, had an average higher monthly usage of factor than those with episodic therapy. However, it was determined to be beneficial because of the prevention of joint hemorrhages in these patients. So taking the strategy of prophylaxis to patients with inhibitors in hemophilia, and another study by Conkle and colleagues showed that recombinant 7A also had treatment benefit for prophylaxis in this patient group. So their study had a pre-prophylaxis, prophylaxis, and post-prophylaxis period. And regardless of which dose of recombinant 7A used, prophylaxis was shown to be efficacious in patients with severe hemophilia and inhibitors. So in managing inhibitors in patients with hemophilia, the use of bypassing agents has been a mainstay of therapy. Activated prothrombin complex concentrates and recombinant 7A are the bypassing agents that are typically used and have both been efficacious in episodic treatment of bleeds and also in prophylaxis in patients with hemophilia and inhibitors. Their limitations include their unpredictable efficacy, so there is a trial and error period where patients may need to be treated with both agents to find their optimal therapy. And there has also been an increasing use of prophylactic therapy to prevent joint bleeding in 78% of childhood and 28% of adults with inhibitors. However, treating bleeds episodically or prophylactically with bypassing agents is not the desired outcome of patients who have hemophilia and inhibitors. The ultimate goal is to eradicate the inhibitors. This is done with immune tolerance induction, which is regular infusions of factor VIII or IX administered for a period of weeks to years in an effort to increase the tolerance of the immune system. However, limitations include variable efficacy, 70 to 85% for factor VIII and around 30% for factor IX. And as expected, immune tolerance induction is very time-consuming and expensive. So in considering immune tolerance induction therapy, there was a large study called the International Immune Tolerance Study, which looked at how patients were tolerized depending on their inhibitor level and also what treatment strategy the patients underwent. There were two different dosing strategies: low dose, which was 50 units per kilo 3 times a week, and high dose, which was 200 units per kilo daily. And the take-home points of this study was that those patients who had higher inhibitor levels were more difficult to tolerize, and that also whether the patients received low dose or high dose ITI therapy, both were able to successfully be tolerized. However, the low dose group took slightly longer to become tolerant and also had more breakthrough bleeding. In the United States, typically doses for ITI therapy are somewhere between the low dose and high dose groups in this study at around 100 units per kilo.
Thank you, Dr. Roberts.
My pleasure.
My first question for you is, how can we, as payers, better manage costs and still improve the treatment of patients with inhibitors?
That's a great question. I think that the most important thing is that patients with hemophilia should be managed at hemophilia treatment centers. I think that hemophilia treatment centers help manage cost because we are able to keep track of our patients' therapy very closely and also their medication use. And so I feel like cost is best contained when payers work directly with hemophilia treatment centers so that we can help treat the patient optimally and at the best, at the lowest cost. And it can obviously become very expensive in inhibitors because you have the cost of ITI therapy daily, and that's not to prevent their bleeding. That's just to try to tolerize their immune system, and that can take months to years. And then additionally treating bleeds with bypassing agents. So I think really the synergistic relationship with payers and HTCs is the optimal way to treat patients with inhibitors in hemophilia.
Thank you. And that's interesting to note that with ITI, it can extend from months to years. There's not a set protocol.
Right.
To Dr. Pizzala and Dr. Brubel, do you have any other comments you would like to add?
So Dr. Roberts, since we know some of the risk factors for developing inhibitors, are there any strategies for preventing their development in the first place?
Yeah, that's a great question. So we're still learning a lot about inhibitors in hemophilia in the United States. And there's a large ongoing study right now through the National Hemophilia Foundation called My Life, Our Future, where we're trying to gather the genotype data on as many patients as we can in this country. So for prevention strategies, though, for inhibitors, I think that's largely still in investigation. We know that they happen up to a third of the time in patients with hemophilia A and less frequently in patients with hemophilia B. And that's something that's very important, and we are still actively looking into best prevention strategies for development of inhibitors.
Thank you.
So the next question for you, Dr. Roberts, is how are emerging therapies impacting the use of immune tolerance therapy?
In hemophilia, there are quite a few. So largely those have revolved around factor products made from human cell line, so recombinant factor products from a human cell line. And then also extended half-life products with Fc receptor or pegylation technologies. So we have yet to find out how these new products will change the way that we treat patients with inhibitors. There are some early studies ongoing with some of the extended half-life products to see if potentially these would be more efficacious in ITI. But again, these studies are currently ongoing, so we don't have a good definitive answer yet for what these new products are going to do for treatment of hemophilia and those who have inhibitors in hemophilia.
Great. Another question for you, Dr. Roberts. Can you discuss your insights on the survey of inhibitors in plasma product exposed toddlers, or the SIPPET study?
So the SIPPET study was a large international study that looked at previously untreated patients who were treated with either von Willebrand factor containing plasma-derived factor concentrates or recombinant factor concentrates. And this study had a majority of its patients that were actually enrolled in India and actually in Africa, as well as other sites in Europe and throughout the world. So the population was a little bit different than a typical US population. Also, the study was designed to look at broad classes of factor concentrates. So in the recombinant factor classification, there are first, second, and third generation, and then even moving into extended half-life products. The SIPPET study only looked at first, second, and third generation products and really lumped them together in their analysis. So the large take-home point from that study was that patients who were treated with recombinant factor products had an 87% incidence of inhibitors developing compared to those who were treated with plasma-derived products. But again, that study was looking at broad classes, and a majority of patients in that study were treated with first or second generation recombinant factor products, whereas third generation and more recently developed products are used in the United States. So to really understand the full impact of this study, the Medical and Scientific Advisory Council of the National Hemophilia Foundation will be developing formal treatment guidelines based upon this study. So the data right now is currently still under discussion.
One more question. This one is for the entire panel to consider. From each of your unique perspectives, what are the key issues or opportunities regarding optimal prophylaxis therapy for both pediatric and adult patients? This is open to everyone.
So from the managed care or payer point of view, the most important thing is to know what it is that's being requested for a particular patient and why. So a good and clear explanation of the patient's need for prophylaxis, which is actually the standard of care for many patients, and an understanding of their dosing regimen, and in particular the intervals at which they'll receive doses is really important. So if we have that information up front, that will make it much easier to do pre-certifications or other insurance activities at the time that treatment is initiated. If a patient is being treated for inhibitors, a very serious problem, we understand that, then they're going to need multiple therapies. That is, they'll need treatment to reduce the inhibitor as well as treatments to reduce the episodes of bleeding. And so in that case, we'll have to see some evidence of inhibitors and an understanding of what the treatment strategy will be for that patient over a period of time.
Thank you. And if I could add on that, I think also speaking from my payer perspective hat from the Henry Ford Health System area, in addition, when a patient gets inhibitors, we also like to have much more frequent contacts with the hemophiliac treating physician to understand if there's possibility of tapering, when would that occur, what inhibitor level are you going to be looking for, just so we can make sure we're following through step by step and not just delivering very high doses through our specialty pharmacy if that's the way the product is being given to the patient.
Yeah, I think that's a really good point. And it comes back to the fact that the overall goal in treating patients with hemophilia is to prevent bleeds, whether they have an inhibitor or not. And so I think that's why it's really important as a director of a hemophilia treatment care center that we keep in close contact with our patients to monitor their bleeds and really to tailor their individual treatment regimens to help them participate in the activities that they would like to participate in and also prevent bleeds. And especially when they have inhibitors, that can be definitely more of a challenge.
Thank you very much.